Okay. Yeah, well, then we'll get ready to get started. Thanks everyone for coming. Welcome. This is the next part of our palliative care series, My Life, My Death, My Decisions. This session is going to be around the multidisciplinary team and the role of each part of the MDT in the palliative care process. The format of tonight is going to be an interview style sections where we speak to each part of the MDT, ask them about their role, how their roles changed, how they would like to see their role change in the future. And then at the end, we will have a section where we will be able to ask the MDT questions. Before each section where we speak to a different healthcare professional, we will ask the attendees to give some ideas as to what that professional does. So we will put up a whiteboard, and using that Menti code at the top, you'll be able to send in your ideas as to what each professional does. We'll just move on to the next slide. So this is our speakers for the night. So we have occupational therapy, social work, physiotherapy, nursing, speech and language therapy, pharmacy, and then at the end we have a pre-recorded interview style with Dr. Laurence Dorman. Once we have, got the registrations on to Menti, we will be able to get started. And the first slide that we're going to bring up is just our whiteboard around who are you. So if you could just let us know whether you're a student or a qualified healthcare professional. There's another student. And obviously this webinar has been opened up to everyone. We haven't said that it's for students, we haven't said that it's for healthcare professionals. We believe that the material covered here will allow us to, benefit not only students but healthcare professionals as well. Maybe you're a student that doesn't fully understand what everyone in the MDT does, and maybe you've learned about your own profession, but you don't know as much about other people's professions. That's what we're aiming to improve here. If anyone's having any issues getting onto the Menti, just let us know in the chat and we can work through that. Emily is on Menti duty tonight, so if there's any issues, she can help us out. And of course, use the chat function. Obviously, if you want to speak to anybody else that's in the webinar, feel free. That's what it's there for. If you at any point have a question for anyone on the panel, we prefer that you use the Menti than the chat function. That allows us to get the questions through to the Menti. Emily can display the questions on the screen and we can ask them at that point. Sometimes with the chat function, sometimes things get missed and we don't want to miss anybody's questions. If you have a question, then we value the idea that it gets answered, and we want every viewpoint to be represented tonight. So we have mostly students, but there's some healthcare workers in there as well. That's good to see. Okay, so we will try the next question. So, do you know a lot about the roles of each healthcare professional in palliative care? This is obviously your opinion. Maybe you feel like you do know a good bit and you feel like you could still improve. Maybe you choose a bit, or you feel like I'm completely clueless. I don't know what anybody does on the MDT and I want to learn. Then that's fine. That's what we're here for. That's good. We've still got participants joining. Somebody very confident knows what all the rules do. Great. You should be on here educating us. Okay, that's no problem. So kind of the consensus is most attendees know a bit about the MDT, but we're kind of here to develop that knowledge a bit further, go a bit more in depth about the roles of each professional in the MDT. That's fine. So first up, we are going to go to occupational therapy. So if you want to just go on to menti.com using that code, our question to you is, what is the role of an occupational therapist in palliative care? We'll obviously speak more on that whenever we speak to our occupational therapy speaker. But just in your opinion and your experience, what do you think the role of an OT is?
So some of the answers coming up are to maintain functional ability, making the home more suitable towards the patient's progressing needs, to increase patient comfort, maintain function and quality of life, fatigue management, to help people remain at home, to make sure that a person has all the equipment necessary to make their life easier with whatever condition they're living with, and to ensure the patient has all the equipment they need and can use it safely. So we can speak to Carolyn now just to clarify the actual OT role in palliative care. Hi, Carolyn. So if you just like to introduce.
Hi, Lauren. Thank you very much. And thank you very much to the committee for inviting me to take part tonight and to represent occupational therapy. Those responses weren't too far off the mark. And certainly I would see our role as all of those things and more besides. So in terms of defining occupational therapy, generally, really occupational therapists offer practical support to people who experience illness or disability to allow them to participate in occupations. And when occupational therapists talk about occupations, we're talking about activities that we need to do, that we want to do, and really just to ensure we can live our best life possible. And I suppose when somebody's given a palliative diagnosis and are living with a palliative illness, they very often are experiencing decline in their functional ability and their ability to engage in the activities that they want to, but they still have a right to live as full a life as possible. And occupational therapists really look at that relationship between the occupations that people want to do, the person themselves, and the environment that they're living in. So a lot of mention there was made of home adaptations and equipment, and certainly the environment is a big part of our role. So I suppose in essence with occupational therapy, what we do is intrinsic to who we are and to our well-being and how we perceive ourselves. And like a lot of other healthcare professionals, occupational therapists would see themselves as very person-centered, delivering very holistic care, which is the cornerstone of palliative care. But we're also dual trained in physical and mental health, so are in a position to look at that physical and psychosocial issues. So I kind of think that sort of is a summary of what we do. Is that a fair comment, Lauren?
So Carolyn, what do you think is the aim of occupational therapy then within palliative care?
I think the aim is to allow people to participate in the occupations that give meaning and value and make their life worthwhile. And regardless of how short or how long that life is, it's about helping them and supporting them to participate as fully as possible.
Yeah, definitely. And what would be the typical occupational therapy interventions that would be implemented within palliative care?
Certainly, I worked for 15 years as a Macmillan occupational therapist. I'm currently lecturing in the university, but if I go back to my role, certainly the first thing I would do when I would work with someone or who would be referred to me would be to identify the occupations that are important to them. So that might be, and very often it's about self-care. So, you know, people are very independence and ability to look after themselves is really important. It's the cornerstone of what they do. For others, it's not so important. They may be willing to let that go in order to do other things. But it'll be looking at those occupations that are important, that prioritized by that person and their family maybe as well. And then looking at whether that be leisure or self-care work. But then there are some occupations that are very specific at end of life. People very often, you know, the occupations of sort of almost preparing for end of life, things like creating a legacy, sorting out, you know, their life, maybe creating meaning for their life. And for a lot of people as well, one of the occupations they would say at end of life is managing illness. And I know a very dear colleague of mine, one of my nursing colleagues, she said that her occupation in managing her advanced breast cancer was to attend appointments, to, you know, try and eat well, to keep active, to go to the gym, to, you know, take exercise classes. She was trying medication to help her relax. So sometimes that can be an occupation in itself, just trying to stay well. And I suppose then we would look at the person, so the impact of the illness on that person, whether that be physical disability, cognitive or perceptual problems. It might be the symptoms of advanced disease, so it could be fatigue, breathlessness, anxiety, pain. So we would look at supporting people to manage those symptoms, to allow them to engage in occupation. So it would be maybe non-pharmacological symptom management. Occupational therapists are involved with their AHP colleagues in rehabilitation. It might be cognitive and perceptual strategies, you know, helping them to manage maybe perceptual difficulties in getting dressed, very functional based things. And then finally, our role really is in assessing and adapting the environment. So allowing the person to be independent in their own home. And it might be to allow them to be independent, but it's also maybe to help support the carers. You know, people very often want to be at home, they want to stay at home, and they maybe want to die in their own home. So our role might be to help actually support the carers and the family to look after their loved one and to be able to do that. So it could be housing adaptations. You know, an inaccessible home environment can be really detrimental to somebody's well-being. We've all experienced it a bit. I mean, COVID and the stay-at-home message has given us even just a taste of what it's like to be confined to your own home, that social isolation that you experience. And then, so it could be, you know, it could be ramps, it could be equipment to help with ADL, it could be wheelchair, it could be equipment, it could be wheelchair specialist seating. We're involved in posture management, pressure management, prescribing wheelchairs. Any of those things. So those are just some of the things if you think about our engagement of the person, the occupation and the environment.
The role's really broad then. So you said there about AHP involvement. So what do you think the role of the OT is within the multidisciplinary team?
Well, I mean, I think all my colleagues and panelists would agree that, you know, palliative care can only be delivered by an integrated team with the person at the centre of it, the person and their loved ones at the centre of it. And I think occupational therapists, along with our AHP colleagues, we're experts in rehabilitation. So we bring that rehabilitation, enabling self-management kind of approach to the model of palliative care and to the delivery of palliative care. And, you know, for us, our specific skills are about analysing activity, about supporting people to adapt how they engage in that, and modifying the environment is a big one.
Yeah, definitely. And how can OT support patients then at the end of life?
Well, I mean, obviously the practical support through, you know, our advice, our rehabilitation equipment and adaptation. But I think as well, again, as part of a team, that offer of psychological and emotional support. I mean, patients are adapting to losses, and for us, you know, functional loss is a huge thing that they have to adapt with, and emotional adjustment, you know, dealing with loss, it's really integral to palliative care. And I think we all as healthcare professionals have a duty to care to our patients to provide that.
And just finally then, Carolyn, what qualities do you believe that future occupational therapists require to work within palliative care?
That's a difficult one. I think, you know, all the skills that you need to be any kind of healthcare professional apply to palliative care. And I think occupational therapists and healthcare professionals need to, you know, be able to adopt a palliative approach regardless of where they're working, because people with palliative diagnosis transition through all different services, sectors. It's really important. But I think a couple of things I would say is, you know, communication skills are critical everywhere, but I think in palliative care, the difficult and sensitive conversations need that very compassionate, empathetic type of communication. I've mentioned teamwork and is that collaboration. I think one of the things I would say as well is flexibility and adaptability. I mean, I'm sure some of the others will agree with this. You could have come in to work with a diary booked out with maybe 4 or 5 appointments, and within 10 minutes, your day has completely changed. People have gone into hospital, or there's been a crisis and somebody else needs your attention. People's conditions change very quickly. So I think you need that. And the final thing I would just say is you do need a certain amount of self-awareness. You know, you're surrounded by distress, and you need to be able to recognize your own stress levels. And I suppose I would say as well, you need to be, there needs to be an element of optimism, a bit of a glass half full kind of person.
Yeah.
But yeah, I kind of think it's all those things and more probably.
Yeah, definitely. Carolyn, thank you so much for sharing an OT perspective. You've given a really good overview in palliative care.
Thank you.
So next we're just going to find out about the social work perspective in palliative care. So if everyone would just like to click back onto Menti and just fill in the question of what they think their role is. So some of the answers coming in is helping to organise rehab and nursing home places, arranging a hospice or care facility, ensuring that the patient's environment is appropriate for the situation that they are in, supporting families who are struggling, assessing home suitability, to ensure the patient is getting the care package they require and to support the family with the care package, providing support to the patient and their family, also providing physical, emotional, psychological support, and signposting, advocating, and being there for the patient's overall well-being. There's quite a lot of responses there for that one. So just speak to Deidre now just to clarify the role within palliative care.
Hello, Lauren. Thank you. You want me to? Well, that's a bit of a mixed bag there, Lauren, isn't it? Yeah, and I'm not surprised. Very often people do associate the social work role with, you know, commissioning services. Yeah. So it is packages of care, nursing home placements. To be honest, that really wasn't part of my role, other than, you know, helping people navigate the system so they could get through to core services, maybe to do that, because I didn't have a commissioning role. But some of those, I mean, you know, if I were to award points there for some of those responses, there was a 10 out of 10 in one of them, which is really about that psychosocial support. There is a concept in palliative care of total pain, and the part of that is that spiritual angst and emotional or psychological angst that people will feel when they realize they're now living a life that is limited. So my role would be very much trying to support people through that, whether it's through life review or advanced care planning or maybe even helping people just be with those really tough issues of shame, regret, loss, those kind of things. But I know you have a list of questions, Lauren, so I don't want to preempt. I don't want to preempt the next one.
So, Deidre, what is your role within the multidisciplinary team?
Well, there you go. How perfect is that? So, well, as a social worker within the team, you know, we work, I suppose. I'm always very conscious when I notice on Twitter or sometimes even at meetings, you know, there can be a very competitive spirit. Not all of it healthy, Lauren, I have to be honest. Very competitive spirit about my discipline, my profession, versus yours or that.
Yeah.
In palliative multidisciplinary teams, the experience is very different. It has been certainly my experience, where we really did manage to have almost a blurring of roles.
Yeah.
So, for example, if Fiona and I worked together in Southern Trust, and Fiona is a speech and language therapist,
Yeah.
so there are times Fiona would have come back from a visit and said, I was out doing, and I'm not going to let on what she was doing because she'll be speaking to you in a minute or two, but I was out doing X, Y, and Z. And I noticed during that visit, there seemed to be a wee bit of conflict between son and daughter. So
Yeah.
Fiona would say to me, would you come out with me in the next visit and maybe we can just
Yeah.
see if we can get a handle on that. So my role would very often be from within and outside of the palliative care team, advanced care planning,
Okay. Yeah.
a life review where people had an opportunity just to drift back over the memories of a life lived and to
Yeah.
honor that in some way, to facilitate communication, Lauren,
Yeah.
because sometimes people, uh, particularly those with a palliative diagnosis, can be afraid. So I'm afraid to say anything to my husband because I don't want to upset him. He's afraid to say anything to me because he doesn't want to upset me. And the two of them are kilt, not upsetting each other, but they're not talking about what
Yeah.
might be useful to talk about. So sometimes my role would have been just to facilitate those kind of conversations. And I suppose the other big one, Lauren, would have been where there was conflict. And I know that all of my MDT colleagues would have been very keen to invite me in on those occasions where they had stumbled across some kind of family conflict. So those are some of the things I'd be doing. Occasionally, I would have helped maybe a mommy or a daddy
Yeah.
with memory boxes, but yeah, mostly that is what I would have been doing, or helping them, or advocating for them, or signposting them
Yeah.
to other services that might be useful.
And would you work with patients then in the community or the hospital, or would it be both, Deidre?
It was in community. I'm not in the team any longer, Lauren, but we were community MDT team.
Okay. Yeah.
And prior to that, before I joined the community team, I worked in hospice for a number of years. So I kind of had the
Experience in both.
experience of both
Yeah.
sides. There is a team, I'm an MDT team in hospital,
Okay. Yeah.
mostly, well, certainly in Southern Trust.
Yeah.
And then we were the community version of that.
Okay. Brilliant. And would you have a lot of input then with the patients' families?
A lot,
Yeah.
Lauren, a lot. As I said to you there before, whether it was, um, you know, facilitating conversations, even
Yeah.
very often. That is, there's a bit of a knack to that, where you have people maybe disagreeing about what's the right thing, or even not fully understanding the information that had been given them.
Yeah.
So you could go out on a home visit, and somebody say, "Well, God, the nurse said that this treatment, so that must
Yeah.
mean there's a cure." And it's
Mhm.
not because the nurse misrepresented the information; it's just
Yeah.
because of people's capacity or
Yeah.
ability to be able to take it in. Sorry, am I going on too long, Lauren? Will I
No,
cut
no,
short?
you're doing well.
You just crack the whip, Lauren. Don't let me ramble on.
So just finally, then, Deirdre, what advice would you give to students considering this career?
Social work.
Social
Or
work,
any, well, palliative care, I'll
palliative care, yeah.
say, I would second what Carolyn was saying about,
Yeah.
um, a high degree of self-awareness would be
Yeah.
really valuable to them. A wee bit of life experience, I think, is always useful as well,
Yeah.
before you would, kind of launch
Yeah.
yourself in there.
Mhm.
Um, and the ability to be able to reflect on your own
Yeah.
practice, I think that is really key.
Important. Yeah.
But the other thing about it is not to be too precious about yourself, and be able to trust and respect the other professionals and
Yeah.
disciplines
Definitely.
that you're working with,
Yeah.
because it isn't a competition. And as Carolyn said, it does take all of us to provide a holistic service,
Yeah.
so that person lives, as Carolyn said, their best lives for until they die.
Yeah. Thank you, Deidre. You really
No
highlighted
bother.
the importance of social work and the multidisciplinary team.
Sorry, I didn't hear what you said there, Lauren. Was there another question, or were you saying goodbye to me?
I was saying goodbye to you, Deidre.
Oh, lovely. Bye.
So we'll just pass over now to Aidan, who'll
Yeah, thank you very much, Lauren. So next up, we are moving on to physiotherapy. So before we speak to our speaker, what is the role of physio in palliative care? Just back on to Menti again, and then after about 30 seconds, then we'll move on. Yep, so some of the ideas coming through: physical movement, rehab, maintain functional ability through movement, maintain function, mobility, reducing fall risk, helping patients to be comfortable, helping with mobility and stiffness, ensuring safe movement and maximizing independence, to facilitate a comfortable physical experience to help a person be more comfortable with an end-of-life palliative diagnosis, and then physical equipment to support client education around movement, pressure, breathing support, falls risk. Okay, those are all great. So I would now invite our speaker on physiotherapy, Jaquie Gracey. Hi, Jaquie, how are you?
I'm well, Aidan. Thank you for inviting me, and it's very welcome to be part of the panel.
No problem. So you've seen those answers. In your opinion, then, how would you explain the role of physiotherapy in the palliative care team?
I think congratulations, because your Menti responses are excellent. We're all about movement, and physiotherapy is all about movement in so many contexts. And I think movement through comfort is so important, especially in the aspect of palliative care, because physiotherapists are really problem solvers. You know, we come to you if you have a problem around movement, and we're really motivators, and people see physiotherapists as sometimes as physical terrorists, or sometimes as something, but in the true worlds of palliative care, physiotherapists are the motivators who will edge you to do a movement, edge you into exercise, edge you into something that will improve your quality of life through movement. Movement is a human right for all of us, and in the palliative care world, to be able to educate someone around small, tiny goals to help them to achieve their movement is core to what we do. And we are critical thinkers, because we're in there with our toolkit of, we can give you this, if you do these exercises, we can get you those 3 more millimeters of movement that'll help you get into your car to go and visit where you want to go, or we can work on those quads, glutes and hams, and we can get you to help you to move, to go to the bathroom by yourself, to maintain your dignity. You know, all of those tiny goals. And again, we work so closely with all our colleagues and our OT colleagues, you know, about being person-centered and about being there for you. And the question that we promote, and in my world, I work in the university educating our final year physios and complex needs. The question we want you to ask is, what matters to you? So we can get your goals for you together. And we use our toolkit in palliative care, and that may be with our respiratory skills, where we're focusing on your breath and how you're breathing, and breathlessness and fatigue management. You know, all of those skills that we come with to ensure that your breathing is at your optimum to maintain your function. And we come with our exercise toolkit, and looking at your barriers, your facilitators, the things that make you engage with those exercises, those movements that will help improve your function and your quality of life, and our neuro rehab handling skills. And, you know, my passion, you know, I remember working in Canada and meeting the first ever palliative care nurse, and I'm thinking, what do you do? Because it wasn't part of anything that I had learned, but experience has taught me through setting up moving and handling services and working in research and palliative care, that it really is about therapeutic touch and handling and working with carers at those times when someone needs to be handled. How can I help you out of the chair and give you the optimum comfort? So those are the goals of physiotherapy, and they really are around quality of life issues. And in palliative care, it's around all the things that matter to you as a person when you are in that position to be diagnosed with a palliative diagnosis. So it is an interesting place, even. I hope it answers your question.
No, that's great. And you touched on it there slightly. So my just next question would be, how does a palliative care physio interact with the wider MDT in their day-to-day working?
I think physios are always seem to be there as every member is a core part of the team, but physios are around movement and interaction. And I think in palliative care, I've worked with many palliative care physios in the education of physiotherapy, you know, and they would always say that their sense of humor in engaging with the team, their sense of humor in bringing people together to obtain what the patient wants is so key. So physios are always there as the problem solver, as if we can't get this, how can we get that? Or how can we move that? How can we work with our OT colleagues to get that piece of equipment? And, you know, how can we introduce those pieces of equipment that people don't really want in their homes or don't, but we can get them there to make it a positive outcome so that people can see the positive in their function and their functional rehab. And the many physios in the palliative care teams are just so enthusiastic, and they are such motivators within teams that, you know, it's one of those skills that we all have to have, and we have to be, as Carolyn says, a glass half full type of person within that team.
Yeah, and just in terms of physiotherapy provision in palliative care, would you see a physio in the hospital, or would you see them in the community, or would it be both?
I think you'll find a physio everywhere you go, right from birth to end of life. And as I often say, we're in the hospital, we're in the community, we're there in those aspects, promoting those key skills. And, you know, and part of the work that I've done with the researchers that I've worked with through the All Ireland Hospice is looking at that end of life phase too, where we are there with our respiratory care and making sure that we're appropriate there for that end of life phase as people enter into that last 48 hours of life, where you say, where is physio? When does the physio leave? And I think when family and carers see the physio leave the stage or the platform, they know that the end of life is really approaching. So we're there in context right through every stage of diagnosis.
Yeah, right, no problem. And in terms of palliative care provision, since you started working on it, do you feel like it's changed? Do you feel like there are different approaches now than whenever you first started?
Oh, 100%. From that day in Canada when I met the first ever palliative care nurse, which is a long, long time ago in the early 90s, to see how our whole ethos of advanced care planning is coming along, to see how we look at the whole context of physical, emotional, spiritual health, how we move through our models of care from our medical model to our biopsychosocial models, how we're thinking about the person and the patient in the center. I think physiotherapy wise, I see an excellent evolution of, rather than diagnostic and we're treating a condition, that we're treating a whole person, and we're looking at that person, you know, from a context of what matters to you. And I think Dame Cicely Saunders and her hospice movement developed those questions and have brought that to the fore. And I think as an educator, I find that one of the most exciting advances that I've seen in my whole career of physiotherapy, in that we move forward to that approach of what matters to you rather than what's doing to you. And we've just finished the person-centered practice book for undergraduate students, and in that chapter in rehabilitation, it has all been about listening to the patient and giving that skill of how you listen to the person and what's important to them. So I'm enthused by the evolution of palliative care, and I think the advanced care planning, all of that agenda, if that helped people to live well and to live well with dying, that can't be anything but good.
Yeah. And then just finally, you touched on it there about patient-centered care, but is there anything else that you would give advice to students coming through, physiotherapy students that are looking to work in palliative care? You know, what would you say to them?
I think physiotherapy students coming to work in palliative care, there is such an important aspect of person-centered touch. And when I actually physically touch you, and I think COVID has brought that to the fore, how important that touch is and how we handle a person. And, you know, it's such a privilege for a physio to go in and work with a family and teach a family how to roll, how to turn, how to manage a new piece of equipment, how to be part of that whole person's journey through life. And move, as I said, it's part of your human rights, and it's a privilege that we can move. And COVID has linked us into the home, but you know, you can move well in your own home. And if you can still get to your front room, which has a step, and we can help you to achieve that, and we can minimize your risk of falling and keep that in your environment, that is the most important job a physio can do.
Yeah, that's no problem, Jaquie. Thank you very much for joining us.
You're very, very welcome.
Okay, so we are then going to move on to our next speaker. Our next speaker comes to us from nursing. So again, we'll pose the question to any attendees. What is the role of a nurse in palliative care? And then in around 30 seconds, I'll come back on and then we'll speak to our nursing speaker. Okay, so a few emerging trends we'll have coming through is around patient comfort and patient care, carrying out the care plan and making sure that the needs of the patients are taken care for or cared for. And then we'll have a big fan there, everything coordinator of all. So there you go.
That's a nurse, put that up
That's
there.
definitely a
Obviously,
nurse.
It wasn't me.
It wasn't
wasn't
you.
me.
You weren't on mentor, or no. And then we'll have to manage the patient's pain, general medical well-being, comfort and emotional support, either in a medical setting or delivering at home. And then assessing what matters most to the family and those close to them, identifying MDT services, kind of care patient review. Okay, so we will then go to our nursing speaker, which is Karen Bowes. Karen, thanks for joining us.
Thank you for asking me, Aidan. Thank you very much for your responses. So I suppose really in nursing, we have to be different. And there are different nurses within the MDT. My experience is within community, and I'm the lead nurse within the team. So I have quite a big role with community nursing. So with the district nurses and some of the other specialist nurses to support them to provide end-of-life care. But we have district nursing who would be the key worker in the majority of cases in end-of-life care. And then we also have the hospice nurses who also work within the MDT, and they are out supporting the symptom management of the patients as well. So I suppose nursing, we've different facets and different types of nursing working in the MDT. I think last year the NMC recorded over 140 different nurses with different titles. So I think that just shows you that we just love to spread our wings. So I'm not sure I would say we coordinate all, we support everybody, but I think we do have a bit of an inflated ego, and there is a lot of us doing a lot of different things. So to speak from my experience, I'm the lead nurse within the team. I also manage the community palliative care team. So I have a little bit of that management, performance management, kind of justifying why we exist as well, and a bit of service improvement. And the clinical work that I do is in and around complex cases within the community. So that's kind of really the facets of me, and I would do a lot of training within the community and also within hospital. I also have the pleasure of working 1 day a week for the Royal College of Nursing as a senior nurse in professional practice and policy. So I don't escape palliative care there either. I'm not going to mention anybody that might follow you around, McKenna, to the RCN and different places. Once you think you're out of the palliative care world, you're sucked back in again in that job as well. So quite a diverse role of nursing within the palliative care MDT.
Yeah, that's great. And then in terms of yourselves with interaction with other healthcare professionals, in terms of, a palliative care case, who would you come in contact with?
Everyone, I think, Carolyn and Jaquie have said it, it's a village approach within palliative care. There is not one profession out there that can do this work alone, nor would we want to. I think we have such a very healthy respect for each other, and working in an MDT, one of the things you learn early on is to understand the roles of each of your colleagues. And we have such a great appreciation for each other, and we support each other tremendously. But within the patient care, exactly how Dee describes, one of the social workers or occupational therapy will go out with someone, and the next thing they'll be rapping on your door and they'll be saying, can we chat about this patient and how we're going to support them. So and at this minute in time, I suppose throughout COVID has kind of pushed a different version of ourselves, which is that virtual link that we do with each other. Quite challenging in any form of healthcare, but I don't know if we're so touchy-feely in palliative care that I think we find it exceptionally difficult. I do welfare checks every Tuesday for half an hour with my team, just so that we can see each other's faces, that we can provide that bit of support. But in palliative care, we are quite tight knit group, and that kind of springs on to, then you can see that when we're supporting our patients.
Yeah, of course, that's very important. Just in terms of the nursing profession in palliative care, it's a similar question to what I asked Jaquie. Do you feel like it has changed since you started working in palliative care? Do you feel like the approach has changed as well?
Oh yes. I mean, everything we do is evidence-based. So we're constantly changing what we're doing. We're constantly seeing new drugs. We're seeing a lot of patients now who, when I'm working in specialist palliative care 11 years, but for the 12 years prior to that, I was district nursing sister in Belfast. And I mean, we're seeing now patients that are living so much longer and are maybe having more symptom management, more longer term contact with you. And that has changed the role, and it has changed what we do. We're also saying, within nursing, the Northern Ireland Practice Education Council has set, very, precise standards and guidance and competency frameworks for nursing. So we are seeing nurses diverse a lot. We do specialist practice qualification in nursing, which is part academic and part placement. So we're seeing a lot more of that as well. From I started nursing, I hold 3 specialist practice qualifications, so it's one of those things you get an interest in nursing, and we have the avenues to pursue that. So yeah, things have changed vastly within nursing, and I expect in the next year or two we can see that change again. I think that this is changing times for all of us as well. So
that was just what I was going to go on to then next. Have you any sort of ideas or suggestions of how you feel palliative care nursing could be improved?
Well, yeah, I mean, definitely. I think that we need more of us, and that's our common mantra. And I'm sure all my colleagues will nod their heads. And probably like most managers, I've many IPTs through to develop and improve and expand the team. Our numbers in palliative care, people requiring our input and our support is increasing, and we need to roll with that times. And I'm sure some of the other events you've held, there are really 4 pillars of our sort of service improvement within palliative care. They identify our patients, advanced care planning, key worker, and specialist palliative care. And, you know, the reason that those are our pillars is because we know that our palliative care patients are going to grow. We're going to identify more of them, and those patients are going to need more support. And from a specialist palliative care perspective, I think we need to move into the 21st century. We need to be a 7-day-week service. We need to be more accessible. We need a good provision both within hospital and within community. So I think there needs to be a lot of investment in palliative care, but that's recouped by the patients. You know, the patients and the people that are important to the patients will reap the benefits of that.
Yeah. And then just finally, what we're wanting to get off everyone is, what advice would you give to students coming through, nursing students and students generally working in palliative care?
You know, I think there's a misconception that working in palliative care isn't rewarding. It's very rewarding. You know, being with someone and improving their function, giving them some rehabilitation, reducing their pain, whether or not that's physical or spiritual pain, you know, that is so very, very rewarding. You know, there's a lot of wins in palliative care. And I think that would be a message that, you know, it's not doom and gloom. It's not depressing. You know, you will get a lot of job satisfaction in palliative care, and patients and families, you know, are so grateful. And the whole palliative care, you know, environment here in Northern Ireland, we're not a big country. We all mostly know each other, and, you know, we're a very supportive group, very supportive crowd, and we're trying to be quite progressive at this moment as well. So what I would say was go into palliative care with an open mind. And really and truly it's a very rewarding area of medicine to be involved in.
That's great. Thank you very much for that, Karen.
Okay.
That's been very informative. Thank you for coming. Okay, so next I'm going to hand over to Nuala. She is going to walk us through our speech and language therapist and our pharmacist. So go on ahead, Nuala.
Hi everyone. Yep, so sure you know the drill by now. So we just want to log on to Menti and just give us your opinion on what do you think the role of a speech therapist is in palliative care. Okay, so we have a few responses there. So that's mouth care, maintaining speech integrity, supporting communication, mouth care and safe swallowing, risk feeding, choking, and overcoming communication barriers and nutrition assessments as well. So yeah, they're all really good. So who we have with us today is Fiona Patterson, and she's going to chat to us about what it's like to be a speech and language therapist.
That's great, and some of those responses are brilliant. Oh, I've just had something come up saying my internet connection is unstable. Is it okay?
Yeah, I can hear you fine. I think I'm not sure what
let me know. Give me some sort of signal if something's happening. I would say it's interesting to see mouth care there. It's encouraging to see mouth care there. Just being brought up in general, I suppose. Wouldn't be traditionally one of the key roles and responsibilities of a speech and language therapist, but it certainly is massively important in palliative and end-of-life care for the whole team. So brilliant to see it being identified as a key issue. I would say that for a speech and language therapist in palliative care, we have a few primary roles, and they centre around two key areas which were identified correctly there around communication and swallowing difficulties. So really what we're doing, along with the rest of our members of the MDT, are optimising function in those two particular areas of communication and swallowing. So we're providing support, advice, guidance, information to families and carers around those two key areas. We're developing strategies in order, a bit like what Carolyn was saying earlier, in order to support the patient's role and goals in decision making, maintaining social closeness, fulfilling end-of-life goals. So some of those end-of-life goals that Deidre was talking about around life review and advanced care planning and memory boxes, the speech and language therapist can feed into those by supporting communication in that. So you already quite quickly see how much overlap there can be within the MDT in palliative care, because we're all working together to help the patient reach their goals. And then the other big part of our work would be around, somebody did correctly state there, around end of life care and progression of swallowing problems, and maybe looking at plans for enteral feeding versus non-enteral feeding, what we describe as risk feeding. So those patients who maybe continue to eat and drink orally despite it being perhaps causing a risk to them, and all of the advice and support and information that they and their families require. So it's a very varied role, and a role that links very closely with all of the other members of the MDT.
Yeah, that's great. So what kind of patients would you see on a day-to-day basis?
That is a very good question. I suppose it's a good opportunity to talk about the change in palliative care services in Northern Ireland in recent years. I think historically, and I'm sure my colleagues will agree with me, historically palliative care and cancer were seen as one and the same, and palliative care was focused very much on cancer care for a very long time. And in recent years, and I think the work of palliative care in partnership across the region, Northern Ireland, has been really key in this, in pushing forward the agenda that there are a range of long-term progressive degenerative conditions that are really key to focus on in palliative care. So as a speech and language therapist, I would certainly have seen patients with head and neck cancer, lung cancer, esophageal cancer, but more often than not, we'd have been looking at those long-term progressive conditions like MS, motor neuron disease, Huntington's disease, Parkinson's, dementia. So a real range of conditions, I would say, but certainly with a greater awareness in recent years that palliative care is not specific to cancer care.
Okay, and would you work mainly in the community or see people inpatient, or a mix of both?
Me personally, I've just recently changed role, but I worked in the community palliative care team for 5 years. There are speech and language therapy is an emerging field in palliative care, and so there are fewer of us than, say, perhaps our physio counterparts. That is growing and changing, which is brilliant to see. But you will find us more so in community at the moment. There are some roles in hospitals, and they're very much needed, but at the moment we are more based in community teams, and that certainly was my experience.
Mm-hmm. Okay, and how would you interact with the other healthcare professionals then? I know you've had a good chat about the MD, but specifically out in the community.
Yeah, there's heaps of examples, and as everyone has really, I think the theme that has been emerging is how closely the palliative MDT do work together, and certainly that is not unique, but certainly is a key part of palliative care, is that we are a very close-knit team. So Deidre mentioned an example earlier of my being out to assess somebody's swallow and identifying that there were some more complex issues around family dynamics that needed work with. So I would be talking to her about that. I might be out with a patient who's having some swallowing problems as a result of their lung cancer or respiratory difficulties, and I might identify a need for some physio support around breathlessness and management of that. Sometimes I would be out with a patient who needs access to a communication system, but it might require some adaptations to their wheelchair for that to be successful. So we'd be working with the OT around that. And more often than not, what you would have found in our MDT was the referral might come into one of us, one professional initially, and we would be talking to the others and saying, this person doesn't need you yet, but I anticipate they will, because what we know about the disease trajectory is that we know they may come into difficulties where they might need medications managed later on, or they may need, I've actually just twigged that we don't have a dietitian here, and I should have been flying the flag for them a bit more if I'd copped onto that. The dietitian would be the other person in the MDT that I would have worked most closely with. So very often I'd be going out to see somebody with swallowing problems and saying, I don't feel this person is actually going to be able to meet their nutritional requirements now with their swallowing problem. So wonder, would you come out with me the next time and give them some more detailed advice around oral intake and things like that. So there's any number of ways that you could be interacting with the rest of the MDT.
Yeah, that's great. And what kind of therapies or treatments would you use with patients to try and help them overcome all those issues?
I suppose when I think about my work as a speech and language therapist, the clinical input isn't really that different. It's the context in which you're providing the clinical care that is the difference. So we would certainly be providing rehabilitation in the same way that we would in other conditions. So therapeutic interventions like some physiotherapy or dysarthria therapy, or any of the things we'd be doing with anyone with those conditions, but with I suppose a slant on it that we're aware that things will change and the person's condition will progress. So if I was implementing some form of alternative and augmentative communication for somebody, I would want to be thinking ahead to, okay, when they're no longer able to do this, what's next? So you're always kind of one step ahead of yourself. So it's not that the interventions themselves are enormously different. It's that you have to think about, you always have to be thinking one step ahead, and the context is slightly different too, because some of the people we're working with just might not be ready for thinking ahead. I know as a professional what might lie ahead for them, but they might not want to go there. And so it's really important to respect that and to go at their pace as well. So it's a constant balancing act of, you know, I know they're going to need this piece of equipment, you know, so in my head I'm thinking, wouldn't it be great to get that ordered? But they might not be ready to consider that as the next step in their journey. So it's balancing those two things.
It's great to hear that SLT is having an emerging role in palliative care. So how would you say it's changed since you started working until now?
Whenever I moved into my post, there were only, I think, 2 others in the region. There was one in Belfast and one in Southeastern Trust, who were kind of the pioneers of our role in palliative care. And now there are maybe 5 or 6. So the first big change is the recognition of our role in palliative care, and a lot of the work that the Regional Specialist Palliative Care AHP Forum have done has really been supportive of that. And there are some documents that we could maybe send on later around symptom guidance around the role of AHPs in symptom management and palliative care that has really kind of highlighted what we can offer. So I would say probably the biggest change is a growing awareness of what we can do and how we can support people with life care needs. And I suppose then the other piece is just what Karen was saying about the increase in complexity of patients that we are now seeing in the community. People are living longer with more long-term conditions, and so their needs are greater. People who maybe 15, 20 years ago wouldn't have survived their cancer treatment, for example, are now living much longer, but they're living with after effects, for example, from their radiotherapy causing them difficulty swallowing or communicating or whatever. So there's lots of changes, but really positive from a speech therapy point of view.
Yeah, just finally, the tough question everyone gets, what advice would you give to people coming into your field of work?
The best advice that was ever given to me whenever I moved into palliative care was sit down, slow down, and be quiet. And well, actually, be quiet is the more polite version of what was actually said to me, but I'll keep it at be quiet. And that, if you follow that, you can't go too far wrong. You are being invited very often into somebody's home at a very special time for them, a very difficult and a very challenging time for them. And more often as clinicians and healthcare professionals, we go bouncing into situations full of ideas, full of things we can do to help, wanting to get the job done, very task focused, very task orientated. You know, you see the clinical information and you think, yep, I can help with this, and this. And what I learned from my experience is 90% of the time I've arrived, that's not what the patient wanted. What I thought I was there to deliver and what I thought they needed is not what they wanted, is not what they needed. And the most important question to ask them is, what matters to you? What do you need? And what do you want from me here today? And taking the time to sit down, to slow down. Skills probably across the board, to be honest, for clinicians, but certainly in palliative care. And the other thing I suppose I would say is not to be scared. Skills take time to develop. Here today who doesn't regularly come back and say, I saw this today and I just don't know, or I had a really difficult visit today and I'd love to talk about it. So it's not feeling that you need to know it all or be able to do it all, because the day you think you know it all, I suppose, is the day you need to retire. And unfortunately, that's a good 30 years away for me. So,
well, that's great. Thank you so much. That was really informative. I really, really appreciate it. Okay, so next up, we're going to be having a look into pharmacy and its role in end-of-life care. So you can all go back onto the Menti and put in your suggestions of what do you think the role of the pharmacist is. So we've already got a response then about syringe drivers. Yeah, and we're talking about pain management, making people comfortable, contraindications, and yeah, drugs mainly. Okay, that's good. I think that's all the responses we're going to get. So we'll have Jaquie Hanley with us today. She's going to have a chat to us about what it's like to be a pharmacist in palliation.
Yeah.
So what did you think of the responses? Were they accurate?
They are, yes. I think drugs, whoever said that was bang on the money. That's what we're all about. We're all about the medicines. The official drugs, I'd like to point out, not the under the table stuff. I'd probably just like to start by saying thanks very much for inviting me along to this today, and a bit of a well done as well to use a forum, I think, for identifying palliative and end-of-life care as a subject for discussion, because I think particularly when you're early in your career, people tend to shy away from it, and it's something that will affect you in no matter where you work, no matter what setting. It's, you know, end-of-life care and palliative care tend to cross all those sectors and all those specialties. So kudos to that. I think it's as well, it's important, and I don't know if maybe it's just the pharmacist part of me, but to clarify that end-of-life care is part of palliative care, but that palliative care isn't end-of-life care, if that makes sense. It forms a section of the palliative care that we deliver, but we do a lot more than just end-of-life care, as many of my colleagues here have sort of alluded to as well. And I think that's particularly prudent when we talk about syringe drivers, or as we should be referring to them now, syringe pumps. There's a lot of connotations about what we call them for patients. But certainly when as a pharmacist, as a specialist palliative care pharmacist, we are all about the medicines and how, medicines are core to the management of symptoms for patients, irrespective of what stage of their journey they are at. And what we want is to make sure that the patient gets the medicines in the best way for them, and that they are safe and appropriate for their individual needs. And that we are managing those symptoms as best we can in a very person-centered way. So yes, as a pharmacist, we do a lot of very palliative care type specific things, for example, around syringe pumps or syringe drivers. You know, what can you put together, what's appropriate, how much can you increase doses by, and the list goes on. And a lot of liaison with, I suppose, particularly our nursing and medical colleagues around that, to make sure that when they're prescribing and administering those medicines, that they are safe and appropriate for that patient. It's all about as well making sure not only can the patient use the medicine, can they get it, accessing those medicines when they need it. So when we talk specifically at end of life, you know, can they get access to the medicines they need when they need them to manage those symptoms? And we'll work closely with our community and nursing colleagues to make sure that if a patient's at home, in their own home, and that's where they want to spend their last days, that they can get access to the medicines that they need to keep them comfortable should they have symptoms. And obviously we spend a lot of time counselling patients and their families, or whoever's important to them, about those medicines, how to use them, how to maximise them, so that they understand what they're using and what they're giving. and as I said, lots of advice for our MDT colleagues around the table.
That leads on to my next question, actually. I was going to ask about, you know, how much choice or discussion is there with the patient about the prescribing their meds?
Well, the patient is the boss. Ultimately, the patient is the boss. And while we may have recommendations and we may suggest things, you know, everything is about their decision making. Sometimes it's made not just with them, but with their loved ones. It just depends on the situation. And sometimes the patient is quite willing to defer that decision to the medical team, maybe to make in their best interests, or to their family. And sometimes they have very strong feelings. And something like syringe drivers is a prime example. There are some patients who just, there's a very bad press around syringe drivers, and people feel like when a syringe driver goes up, that's it, that's the end. And I would spend a lot of time counselling patients, not only who I see in day to day, but also at sort of educational groups and things, that syringe drivers are just another way of delivering medicines, essentially, and they can be very useful if you are nauseated or if your bowel isn't working properly. You know, it doesn't necessarily mean that the end is approaching. I've totally lost my train of thought now. This is what happens when you get me on at the end of a long day after work. So what was the question again? Sorry, Noah.
No problem. No, it was just choice and discussion about prescribing to the patient, but I think you've answered it really well. But yeah, it's totally up to them.
Yes, so I suppose all I was going to say was that basically, if a patient feels very strongly about syringe pump and they don't want it, then we can't force that on them. But all we can do is advise them that it might help manage their symptoms more effectively. And sometimes what you'll find is a patient who says, no, I don't want that, then says, right, okay, well, we'll try it for a few days, and then it works for them. They're like, don't you take that down? That is working for me. Do not touch it. You know, so you'll get all the different patient preferences.
Okay. And as you're based in Macmillan Centre at the minute, what are the hours like? So are you expected to do night shifts and on call?
No, Macmillan unit is a 9 to 5 Monday to Friday gig generally. We're a hospice unit to all intents and purposes, and we are slightly unique from the other hospices in that most of them are independently funded through charities and things. The Macmillan unit is not. It's part of the trust, and we are attached to the main hospital building, which means that the patients we get in maybe might be slightly different than you might see in some of the other hospices. We can wheel them up and down the corridor if they need acute interventions and things. So it's while very much a similar theme, slight difference. The other thing is that our Macmillan unit, as a result of COVID, actually only has half the beds at the minute because we were shipped completely off site in the first surge. So it's not quite as it normally would be. But yeah, I personally, it doesn't affect me and the job that I do because it's a Monday to Friday job, but that doesn't necessarily mean the problems aren't there on Saturday and Sunday. As somebody, I think it was Karen said, we need to be a 7-day-a-week service because things don't just switch off.
And are you an independent prescriber? And if so, how does it benefit your role, or would it? Yeah,
I have to say, I really hope this comes out right and I don't sound negative, but you know, whenever you qualify and you do your final exam at university and you think, that's it, I've crossed the threshold, that's it. And then as a pharmacist, after your pre-reg exam, you do, that's it, I've crossed my threshold. And then there's the next thing and the next thing, and you're continually learning and doing educational things, but you always feel like that's the big thing. But I have to say, being an independent prescriber is probably one of the most useful things that I have done, and it's certainly a skill that I use every single day. And it's from simple things like just tidying up cardexes and making sure it's clear and that, you know, we're reducing the risk of mistakes, to actually actively putting management strategies in place. You know, my role has changed slightly in the last year with COVID, and I'm seeing much more patients in the acute hospital, and that means I'm working with generalists who maybe feel less familiar and less comfortable with this kind of maybe strong opioid use and things like that there. So as a prescriber, I'm able to take responsibility for that and not just be the person recommending it. I'm actually saying, no, it's okay. I'm taking the responsibility for that as a prescriber as well.
Okay, and the big question again, what advice would you give to people who are up and coming who want to go into your field?
See, this is a problem when you go after everybody else. Everybody else has said all the good things, but they're all absolutely bang on the money. you need to have, it needs to be a wee bit of resilience to work in palliative care. It is totally understandably emotionally challenging, but without question, hugely rewarding. I absolutely love it. And I know that people are like, oh, no, how you love that. I don't know how you love that. You know, it must be so sad all the time. But I love that thinking outside the box. And as a pharmacist, quite often pharmacists like to work black and white. Well, this is what the guideline says. And if your renal function is above 30, you get this. And if it's below 30, you get that. And actually in palliative care, you have to be willing to work in the grey a wee bit. In fact, a lot of it, not just a wee bit. So I think a bit of resilience. Don't try and run before you can walk. I think it took me, I think I was the person, both feet were in, I was ready for this. This is me, go, go, go. And actually 9 years later, I feel like now I feel like maybe I have the bones of it. But it's, you know, you do, and it is because you want to do your best and you want to be part of that team that's so effective for the patient, but you will be better. And I know I'm a better person for all that I have learned from all my MDT colleagues. It's made me so much better at assessing patients and looking at that holistic need, which is all what palliative care is about. So yeah, I think a bit of resilience, be willing to work in the grey, and don't try and run before you can walk.
Great, thank you so much. Thanks for chatting with us today. It was fantastic.
No problem. Sorry about my little brain fart there. That was.
Oh no, don't worry.
It's after 8 o'clock. It's getting close to bed.
So I'm just going to pass over to Aidan now, who's on our last speaker. So I'll let him take over. But thank you so much again, everybody.
Thank you very much, Noah. As Noah said, we're on to our last speaker. Our last speaker is coming to us from medicine. Unfortunately, he wasn't able to be here tonight. Late in the day, he was called elsewhere, so he informed me he wasn't going to be able to come. So I met with him a couple of days ago to run through some of the questions. So we're going to play a pre-recorded video. But before we do that, I'm going to just do the same as everyone else. What is the role of a doctor in palliative care? Just back onto the mentor. Yep, so just keep them coming through. So far we have medicines management, overseeing and signing off on medical decisions and decisions involving the patient care. Treatment planning and prescribing, prescribers and referring to others in the MDT. Diagnoses, reviewing conditions, communication with the MDT, all disciplines in the MDT. Yep, that's great. Just wait to see if there's anything else coming through. No, I don't think so. So we will play the pre-recorded video now. This is my discussion with Dr. Laurence Dorman. Okay, so I'm here with Dr. Laurence Dorman. Dr. Dorman, thanks for joining us.
Good to see you, Aidan. Thanks very much for having me. I'm sorry I couldn't be with you in person today. Through a few questions here today about my experience of palliative care and how I feel that can be best delivered in the community. So my name is Dr. Laurence Dorman. I'm a GP. I work in Moore and Family Surgery in Kilkeel, and I have a bit of experience throughout the years in palliative medicine and palliative care. So for 14 years, I worked in Uri Hospice, and then I was always interested when I worked in my houseman's jobs in Daisy Hill Hospital in Uri about palliative medicine and palliative care. So I'm very keen to share you my experiences and how I feel general practice can make a big impact with this in the community. Yeah. So as a GP, we're seeing throughout the journey of our patients. So we're actually seeing at the diagnosis, and then at the treatment, and then potentially the palliative, the end of life care stage with our patients, who have a huge role with that, and have a huge role of connection with patients, both the patients themselves and the patient's wider family. So that's a really important bit. One of the big things I learned when I was working in hospice is the importance of family and how to bring them along with you in the journey. So quite frequently, if you imagine in a ward round in hospice, we would see a patient and then we would go and speak to the family and explain to them where they were in their journey, whether things were coming closer to the end, what interventions we had done, if we had increased their pain relief, what would be the implications of that, might they be a wee bit sleepier. So it's really important that families feel that they have a role in this and that they're brought along with the journey, as it were. Although, of course, you have to bear in mind, patient confidentiality, patient wishes, and so on. So it is a skilled role, and GPs are really important as part of this. So I think today we're talking about the multidisciplinary nature of healthcare and so on. And GPs are a really important member of that multidisciplinary team. It's vital that we reach out to it. So when I was in hospice at that time, our weekly MDT round would have had, the doctors, the nurses, the social workers, and the chaplains, and each of them had a really important role. So as a GP in my practice, one of the big people that we link in closely with is our district nurses colleagues. And district nurses in the community are just real heroes. They do so much work day in, day out with syringe drivers, with giving emergency doses. And it's just vital that they have really good connections with us as a GP practice. It's really vital that when patients develop symptoms, if they have unmet needs such as pain or nausea, that they can get care quickly. So as a daytime GP, and again, I'm using the terms daytimes and out of hours times here, which we're trying to move away from, is that our patients have really good things that are put in place. So we talk about anticipatory care planning. So we put in drugs into the house where if a patient needs an injection, the drugs are there, the needles are there, the authorization sheets are written up. So it's really important that we have that. And we do that as a multidisciplinary team. And our whole practice team is just so important. So in my own practice, we would frequently put an alert message on our patients' notes if they're coming into end of life, which means that if the patient or their family phones in, our reception staff know that they need to be prioritized. So if the family member phones in for a prescription for that patient, it needs to be prioritized. So it's just really important that the entire team, plays a part.
Yeah.
And that's very important.
Yeah.
So moving on, so go ahead, Ed.
No, that's great. Thanks very much for that. We just wanted to ask, in terms of palliative care provision, since you left, university, since your studies formally ended, do you feel like the provision has changed over the years? Do you feel like there's been any major changes that for the better that have improved palliative care?
Yeah, so palliative. So I like to use the term palliative medicine. So when I worked in hospice, we were doctors, so we checked people's blood tests and so on, because it's very important that if a patient has a symptom such as pain, you try and work out what is causing that pain. So just because you have cancer and you have pain in your chest doesn't mean that you can't have heart disease. It doesn't mean you can't have gastritis. Do you know what I mean? There's other things that you have to work out why that patient is sore, what that pain is coming from, and then using the appropriate management, to identify it. So I think that's really important. And again, I've seen huge changes. So when I started in hospice, hospice in those days was preparing for an epidemic of AIDS, and those were, the hospice was established in the 1980s. And it literally was waiting for a lot of people to come through its doors and dying. But as we know, medical science has evolved. We have really good triple therapy treatment. HIV is now an inconvenient chronic disease for a lot of people. So there's huge changes.
Yeah. And in terms of medicines on a medicine sheet, is there any common medicines that you would see more than others on a medicine sheet in palliative medicine? And why might patients be given these drugs?
Yeah, so there's a lot of things, and it's a lot of things to work out as prescribing. So as doctors, sometimes we're very good at prescribing things, but sometimes we're not as good as de-prescribing things. So it was always a big thing to do about checking a patient's sheets, seeing whether they really needed tablets. So one of the big things that when I worked in hospice was statins. So frequently we would have patients, from either community or transferred from hospital with very advanced cancer, with multiple metastases, and they would still be on things like cholesterol tablets and statins. So it is important to take these in context. It's also very important to bring the patient into the conversation. So once we had a patient, I remember very clearly, who was brought over, and she had a lot of cardiac medicines. And at the end of the ward round, I quickly put a line through half of her medicines, but then she burst into tears with me the next day, feeling that she hadn't been consulted and that we'd sort of written her off. And it really hit home, actually, that we need to bring our patients with us, that if we are going to make changes, we explain to them why we're making changes and make them part of the process. That's, you know, patient-centered medicine is all about.
Yeah, that's great. And if you had any sort of advice for a student now that was coming through university and they were looking to work in palliative medicine or in GP practice, what sort of advice would you have for them?
So first of all, be interested in your patient and always want to know more with them about their experience and so on, and never be afraid to go that extra mile. So, I mean, if your patient is admitted as a GP into hospital, don't be afraid to phone the ward. Don't be afraid to send your wishes into the patient and to see how they're getting on, even though it's maybe gone to a different department or not, you know what I mean, general practice if it's gone to secondary care. Be interested in them, be interested in their wider circle. One of the big things we learned to do in hospice was to map out a patient's family tree. And that was always really interesting. So you could work out who was related to who and why family dynamics were what they were, and who related to each other better. Because although you may be a mother and have 3 children, you know, there may be issues there that you're not aware of. And it's just really important, because these are the people who are going to provide the care whenever that person maybe comes out to the community.
Yeah.
In terms of experience, you know, it's absolutely work in a hospice, you know, and as one of your specialty jobs, it's a great place to work. General practice as well, obviously, you know, but there's lots of opportunity.
Yeah, that's great. That's all the questions I've got for you, Dr. Dorman. Thank you very much for joining me this morning.
Thanks very much.
You don't have any other questions yourself?
No, it's a great career. Like to see people I mean, it's literally to do the diagnosis and to provide care for somebody from diagnosis right through to end of life. It can be very rewarding. It can be very challenging. It can take a lot of work, but it's definitely rewarding and well worth doing well.
Yeah, that's great. Thank you very much.
No problem. Thanks very much, folks.
That was Dr. Laurence Dorman. So the next part of our event tonight is going to be our Q&A session. I had written a message into the chat, whether or not you saw is a different story, but the Mentimer is now open for Q&A. If you have any questions for anyone on our panel tonight, or if you just want to send in a general question and see who answers it, then you're more than welcome to send that in. But I will pass over to Emily, who's going to coordinate this bit of our event.
Thank you, Aidan. Hi everyone, this has been a great session so far. I thought at the start I knew a bit about palliative care, but I've just learned so much more now, so I think it's really been great. So we've got a few questions here, and the first one, I'll just throw it out to anybody who wants to come on and speak, but it's how do you communicate with patients? So is that like phone calls or emails, or like do you have like work phones and can you use like text messages or WhatsApp or anything like that? So whoever wants to come on.
I'll jump in because that's an easy one, Emily. So it might get progressively harder and I can count myself out. But yes, all of that, we mostly face-to-face, to be honest with you. And throughout the pandemic, we have continued on with face-to-face within the community and also within the wards. Yes, we would email patients, we would phone them. The speech and language therapists within our team often provide iPads and different things, and we'll communicate that way. But I think the nature of the business that we're in, we do like to get a look at people. So a lot of what we do will be that face-to-face. We haven't really embraced the virtual platform maybe for patients as much as maybe other professionals have, but yeah, we're open to whatever suits the patient. I think it was Jaquie said earlier on, the patient's the boss. So if whatever style of communication that they would like us to use, we will do that.
That's great, Karen, thank you. Does anybody want to come on to add to that, or?
Just to add to what Karen said there about the patient being the boss, sometimes there can be a bit of, some patients and families don't actually want their neighbours or the people down the road knowing that they're unwell, particularly if they're maybe younger or they're still coming to terms with it themselves. So sometimes some people don't like you to come to the house, or they want to know what you're going to be wearing when you come to the house. Are you going to be in uniform? Are you going to have a mask on? You know, so sometimes we do a bit of work on the phone first in that kind of warming up period, where because sometimes you're working with people quite quickly after a very significant diagnosis, and they maybe take a while to kind of accept the role of the palliative care team in their care. So you can do a bit of preliminary work on the phone sometimes before you're actually granted access to a visit, but that will depend on the patient and their needs. Some people will want you out last week and others will maybe be a bit more cautious. But it's just something to be mindful of, that there is sometimes some people can see it as a bit of a, not a stigma is the wrong word, but they just don't want people to know that they're so unwell, basically.
Thank you, Fiona. That's really interesting. It's something probably as a healthcare professional you don't think of, but that's the patient's perspective. Yeah. We'll move on. There is another really good question here. How do you cope with the challenges of seeing palliative care patients every day? So whoever wants to come on there.
Hang back.
Don't all jump in at once.
Is right, is right. Can I just draw someone's attention to a question that has come in on the chat there? It's a question for the Q&A, and it's a really good one. I suppose coping. A few of my colleagues have said already about the privilege of the work. They didn't use that word because we do actually try to avoid using that word. But that there is, there is such a high level of job satisfaction. So there are times, of course, when, for whatever reason, we will be particularly impacted emotionally. Where somebody maybe reminds me of my own family situation, or someone actually looks like someone belonging to me, or whatever trigger that I am particularly touched. So, and that is another beauty of the MDT, because the number of times that, and I'm sure others could agree here, where I can come back into the office and say, do you know what? My heart is broke with what I have just been with there, and can we have a chat about it or have a cup of tea? And that is another of the benefits of MDT working in palliative care. We are able to support each other, particularly when, as I say, for whatever reason, maybe we are finding it a wee bit difficult that day. Ordinarily, it is, I won't use that word, but there is something really special about being able and allowed to sit opposite someone as they talk through, to use the phrase that has been used a few times, what really matters to them. And that includes faith, spirituality, certainly, love and life. To be allowed to sit opposite someone with that, that is just so encouraging and so affirming, I suppose, and such a privilege. So that is there are different ways of managing it, but hold on to the fact that this is we are honored to be there in service of these people.
I think if I could just jump in there as well, I would totally agree with that, Deidre. And I think part of working in palliative care is learning to be with people and to listen. And I think, Jaquie, as you said, and different ones have said, you jump in there, you think you're going to fix everything when as therapists, and just that ability to listen. And I think everybody's very different as well. And I think it is about being able to recognize when it's been tough and when it's been difficult. And it is having that team to come back to be able to say, I've just had a really horrible day, and somebody will look at you and pick you up. And, there's lots of really good times as well, really uplifting and fun times as well, in those situations too. So I think it is very important. The team's very important to back you up and support you.
I can reinforce that too, and physios would talk about their bizarre sense of humor, that, that they have the ability to pick someone up when it just seems just so hard to be part of that. But then, your team that's around you will support you, and humor is a part of resilience, and being able to look on the brighter side of life and appreciate life. And I think, anybody that I've met and worked with in palliative care has always been, you know, such an it's an exceptional role that we get to do. And I think you build your resilience around doing that. And that those are skills that I think you learn with time, and good teams are the key part of it. The people on the team making the best of everything they can for the person.
That's great. Yeah, I think you can really see that you are a very close-knit team. I wasn't expecting most of the people on this call to know each other, but there you go. We'll touch on that question that was in the chat here. It's, how do you ensure different cultures and religious views of patients are always taken into consideration throughout their care?
Suppose just to start that one off, because I'm sure a few people will have some comments on that. Emily, I would say that you have no better person to tell you what their spiritual, religious, cultural perspective is than the person. You know, what some person's Christianity is going to be different than someone else's. So my advice in that is always to ask the person and listen to their voice and what it is that they want. Always be aware that any support that you're giving anyone, that any holistic assessment has to have that spiritual, cultural aspect to it. You know, you can't fraction these things out. A truly holistic assessment will take all of those considerations in. And the other thing as well is that, you know, I think that there's a great onus upon us that, you know, if someone has a culture or a faith or something that we don't understand, is to find out a little bit about it and find out a little bit about what they would like, what they wouldn't like, so that we can support them through their end of life journey. And that's just kind of my learning on things, but I'm sure other people will have their own thoughts.
Yeah, absolutely. I agree with you, Karen, and I would just add into that, you know, I think there's a new awareness. One of the things maybe that I've noticed changing since I started originally in palliative care about 12 years ago, is an awareness of the need for cultural competency. And that is, you know, as we are becoming more and more diverse as a society, then we need to up our game around different cultures and how they talk about ill health, how they broach speaking about intimate aspects of their lives, and how they will talk about dying and death. So as Karen says, absolutely, first thing is ask them, but even just the step before that is, you know, when that referral comes into you, go and do some research. Go and find out what you need to know. Like, you know, what are there any particulars for this particular population profile here? What do I need to know? And then check it out with the person, because we can't presume that a particular culture are homogenous either in relation to how they respond or engage around these life and death issues.
And just on the back of that, are those sort of services to look after someone's spiritual or religious needs, are they like within the hospital already, or would you sort of like outsource that, or does it depend on the person?
Well, I mean, there are chaplains in hospital teams. They don't tend to be in community teams, but you know, for us, I think if that's something that is important to the person, it will come up in our conversations with them and in our assessment, you know, and they will lead that. So it's not something that I certainly as a social worker would be looking to outsource, because it is part of the totality of this person, and however they are articulating that, that's what matters, not whether I agree with it or disagree, you know, but to allow them to articulate and try and find meaning, because that is very often what people are struggling with, is about, you know, the meaning in suffering, or the meaning of life and the meaning of death. What does it mean now? So before I get too philosophical, I'm going to go mute.
No, this is going great so far. There was another question here. Does anyone have any palliative care myths that they want to bust? Is there any sort of...
I'm going to jump in there. That one's just right for me, really, isn't it? I've already touched on the syringe driver, syringe pump thing. That there is this stigma around it. It does not help. That about 4 or 5 years ago, there was a very public misuse of syringe pumps in England, and all the work that we had done with patients to say these are not what you get at the end of life, these are used to manage your symptoms, was kind of unpicked in the media, so that's not helped. So for me, it's very much sending that message that syringe pumps are one of the things that we use to help us manage symptoms. As I said, there are numerous examples. If your bowel's not working, if you're sick, if your tablet burden is too high, sometimes we just use it because the oral tablets that we're using or patches or whatever just won't do what we need them to do, and we can tinker the syringe pump a wee bit more to the patient's needs. So that's one of the big myths to bust, and one of the big messages that I think as palliative care specialists of every specialty, we all come across syringe pumps and patients with them, and reassuring the patients and their families around them and what that actually means. And I suppose the other big one is around when we use morphine and strong opioids and things, particularly at the end of life, that we are not accelerating end of life. And if not every patient who in the last days of their life needs strong opioids, if they are asymptomatic, that's okay, but what we want to do is make sure that they can access those medicines if they need them. And that's very much what Dr. Dorman was talking about there, about the anticipatory meds. And we put those medications in place for patients just in case they need them. And there's a lot of work to be done, I think, across all of Northern Ireland about improving that still, but it's very much about reassuring patients that being prescribed morphine doesn't mean that you're getting worse and your condition is progressing, and equally it doesn't mean that we are going to speed things up at the end. We are forever fighting that balance of managing symptoms without giving you out sedating you too much or giving you too many side effects, and that is the trick in the whole game for from a medicines management point of view.
Another one I would love to bust that is still kind of hanging around, and it's a hangover. You're all far too young to remember the Liverpool care pathway, but it is very much a hangover from that era. And it is that at the end of life, you will be starved and you'll be stopped. Food and fluids will be stopped, and people will be starving and thirsty and will die of malnutrition and dehydration. And it doesn't happen. There was some really poor use of a care pathway that was designed to support clinicians in providing end-of-life care, and unfortunately got picked up. Well, unfortunate that it happened, obviously, but it got picked up and really reported on in the media, particularly in the UK, and it has brought about a lot of fear in the general public around sort of care of the dying and care of the dying pathways, and even the terminology pathway. But a big part of that was the emotive idea that people were being starved, and that their food and fluids were being withdrawn and they were being left. That doesn't happen in that sense. There are various points in somebody's condition where conversations need to be had sensitively with families, patients themselves, carers, full multidisciplinary teams, about the level of active intervention and active treatment that is required and is appropriate. And artificial nutrition and hydration absolutely come into that. But it is not a case of things being withdrawn or stopped suddenly when the patient doesn't want them to and the patient just being left. It's normally something that is titrated down very slowly in accordance with the person's symptoms and their level of consciousness, and looking at other things around risk of pulmonary edema and other complicating factors that are actually sometimes exacerbated by the use of artificial nutrition and hydration towards the end of life. So we in palliative care have a big role in affirming death as a natural process and allowing that to happen in that natural way, whilst supporting families and carers along the way. So yeah, that's a big myth that still unfortunately is lingering. I don't know if anyone else wants to add anything to that.
Can I add a myth buster that you would really love to bust, is that, you know, palliative care doesn't mean no rehabilitation. You know, if you're palliative, rehabilitation has a really active role. So active rehabilitation in palliative care is something that is real and that really happens for the person. You know, we have roles as therapists to improve quality of life, and research and measuring those ceiling effects is really difficult, but you know, for the person to be person-centered, rehabilitation is a part of palliative care. It's not a part of end-of-life care, but it's very much an active part of palliative care.
Can I have one as well? Can I have a myth? Oh, sorry, Carolyn, have you? Okay, will you go?
No, I was just going to say here, Jaquie, I totally agree with that. I think there's a misconception that rehabilitation and palliative care don't go together. And I think, you know, as Jaquie says, the evidence is building and growing all the time. The evidence base for it is getting stronger. So I think maybe just to say rehabilitation is becoming a core part of palliative care. Sorry, Deidre, go ahead.
And mine then is just that palliative care, you know, translates as there's nothing more we can do for you. That is just the worst message out there. So bust that myth tonight.
That's great. Thank you for sharing that. I think it just shows how important language is when you're speaking to patients, that you don't use sort of words without explaining them, because maybe, you know, they have like a certain idea of what that means, but that isn't necessarily true. So that's really interesting to hear from you all. It sort of leads on to another question here. Why are we trying to move away from using the word privilege? So I think, Deidre, you'd mentioned using the word privilege, and somebody wants to know why we're sort of not using it.
Well, it's maybe it's just a wee pet hate. It's just overused, Emily. You know, you know, it's just overused, so it has lost some of its currency. And the other thing, yeah. So, and that's the reason. So, of course, you know, to be, as I say, allowed into that space and time with someone at that time of their life, that, as you've heard, is a really important time for people, is something special. But the only reason I'm avoiding the word privilege is because it's just overused. It's like, anyway, yeah, don't get me started on that, about words that I don't like.
No, that's great. No, thank you for explaining that. There's just one more question here. It's somebody that's a social work student, and they've said, I'm very interested in becoming a social worker in palliative care. I'm currently in my final year placement. Are palliative care jobs easy for social workers to get? And I'll sort of spread that out to everyone. So are there jobs coming up in palliative care at the minute? Is this like a sector that's sort of growing, or where is it going like that?
Well, you heard Karen talk earlier about the number of bids she has put in order to develop services. But just to go back to the end of that person's, what's her name, Emily? Or the question?
I can't actually see the names on my.
I know somebody. I know somebody. The end of her question was, you know, is it hard to, just what was the last wee piece of her question?
Yeah, no problem. So just, are palliative care jobs easy to come by for social workers, is what she said.
No, you have to be really, really special. Really, really, really special. So, you know, if you happen to be really, really special, then they're still difficult to come by, because you know, there's a team, a community team in each of the trusts, and then there's one of the social workers, hospital social workers, will be assume that title in the hospital setting. But because people love the work when they're in palliative care, there isn't a big turnover of staff. So you will find in a lot of MDTs where you have, you know, I was dark haired when I started out in palliative care. You know, it's just no getting rid of me. So it is a bit difficult to get in. But because of the developments that are happening, and last year, even through transformation a year and a half ago, there were additional posts created. So please tell that student social worker to hang in there. If it's meant to be for her, it will come her way. And if Karen gets the money that she is seeking, she will be spreading it around and it will be building the team.
Emily, I think the other thing to say as well is that, you know, an awful lot of roles out there have quite a big palliative care component to it, you know, so you might find yourself as a district nursing, and I know within sort of the teams in Belfast, I would audit their caseloads, and, you know, up to 40%, 50% of their activity is end of life care. So, you know, there may be staff out there who would like, you know, a career in palliative care, but maybe not doing it every day. You know, there would be that, you know, working in places like the cancer centre, you're going to have, you know, oncology and palliative and end of life care. So, you know, you can get quite, you can consume yourself and be all palliative care, or you can have a little bit of it. And in answer to the question, yes, there will be more posts within palliative and end of life care. I think, you know, midwifery and palliative care are the two things that are definitely, you're going to be born and you're going to die. So those jobs will be there. And Deidre will not tell you, but the social worker who was asking the question, you go for interview and then you have to make sure that you have got your Macmillan head tilt that all our social workers have. So just be mindful of that in the interview. Yes, your facial. But yes, there are jobs out there. And again, for our AHPs, and I'll not speak on their behalf, but we need more dietitians, we need more speech and language therapists, or OTs, physios. I mean, I came into the team yesterday and our occupational therapist had a week off and she came into 19 referrals. You know, and that's the game at the moment. So yes, we are all pursuing, and especially with you know, things that have come out in the minute, strategies like the no more silos, there are avenues for us to grow and develop as services and to put in bids for our respective teams. So yes, lots happening.
I was going to add, sort of on the back of what Karen said, and Fiona had mentioned this before, so Palliative Care and Partnership are our strategic lead, and they have done a lot of work looking at what do we need, what sort of workforce do we need to meet the palliative care needs of our population in Northern Ireland over the sort of the coming years, and that certainly has recognised gaps. And I know certainly within pharmacy, and I know pharmacy are not unique in this, but the way that palliative care services are delivered across Northern Ireland actually is very different. When you go from one trust to the next, it's very inconsistent, and that has been recognised as a gap and something that, you know, let's take the good bits and let's replicate it, you know, across the region. And it's also palliative care and end of life care were identified in the New Decade New Approach as a real focus from our Boys on the Hill. But that said, I mean, this year obviously has brought a huge shift in things, but that at that time was identified as a key area for investment. So while posts may be hard to come by, I completely agree with Deidre, you know, that is not because the need is not there or that those posts won't be there in the future, because I think it is something that is developing and will be invested in. She crosses her fingers there, you see that?
Yeah, I would just add to that as well. You know, when I started back in palliative care in 2004, there was only one occupational therapist in the Belfast Trust at that stage. It wasn't even the Belfast Trust, it was North and West Belfast. So, you know, we've come a very long way. And while there's still senior posts, they tend to be quite senior posts that come up in palliative care. I think that will be changing as well. And I would totally agree, Karen, with what you were saying. I mean, our community occupational therapists, our occupational therapists in acute services, they are seeing an increasing number of patients with palliative needs and need to be adopting and looking at that palliative approach. So that experience is going to be building as well, because the reality is the patients, you know, they're right across all the sectors, all the services. So that's building that skill set as well and developing so that then people can move into the more specialist posts and hopefully we'll start to maybe see even skill mix within those specialist areas as well to build the skill, because we really need to build the skill set and the workforce from the ground up, I think would be my thing. And certainly from having been in it for so long and seen it, how it's kind of evolving and developing, I think that's where we need to be going.
I suppose maybe one of the areas we haven't spoken about so much this evening is the independent sector, you know, so our care homes. And again, it's quite an area where there's a lot of development happening there. And I know in Belfast, and I think coming or in the northern area as well, there are specialist palliative care members supporting the care home sector. So, I mean, there's over 16,500 beds in the care home sector in Northern Ireland. And I think what we have learned again through the pandemic, there's a lot of development within that area, and there will be equally development with palliative care services for that area, and very rightly so.
Yeah, no, that's brilliant, ladies. Thank you for sharing that. And I think it is going in a really good direction. If everybody's sort of as enthusiastic about as you are about your jobs, it's definitely going to go in the right direction. So we're not going to keep these any longer. So I think I'm going to hand over to Aidan here just to finish off. But thank you.
Can I just say, Emily, that the question, or the person who asked that last question that generated, you know, such good response there, is called Ursula, and she says she is indeed very special. So yeah.
Ursula, that's good to know, because we need a bit of succession planning, because Fiona might have 30 years left, but I certainly don't, and I'm not calling out anybody else. So we're always on the lookout for our replacements.
Yeah, well, that's good. At least we'll find the next Deidre McKenna in the chat anyway. Yeah, so
There's only one. There's only one.
there's only one. That comes to the end of our questions. And on behalf of everyone on our committee, I just want to say a big thank you to every one of our speakers that has came tonight. You gave your time on a Thursday night whenever you were under no obligation to. And I think that tonight has been very beneficial for improving everyone that's attended's knowledge of palliative care and the provisions that are in place and how we can improve those provisions in the future. In terms of if anyone has any other questions, I have sent our email into the chat there. If anyone has any other questions that they feel haven't been covered tonight, or if they go away from this and think, oh, I should have asked that, send it that email. We will try our best to answer it, whether it be through sending another email to the people that you can see in front of you here and nagging them again, or looking elsewhere. But yes, so overall, I just want to say thank you to everyone that's came tonight, everyone that's attended, as well as a massive thank you to all of our speakers. If all the speakers wouldn't mind staying behind, that would be great. But for everyone else, that's the end of our webinar. Thank you for coming.
I think that's everyone gone in. There's
Yeah, I was gonna say, I think everyone.
Is that us?
Yeah. Sorry.
It's just there is the last straggler, is she? That's
Yeah.
no, that's no problem. I just wanted to, and we all wanted to, our project team, just come on at the end whenever we didn't have any attendees, and just say a big massive thank you to everybody that came tonight. We really do appreciate it. Trying to find people to speak is not an easy task, and sometimes you have to go down a lot of avenues before you find someone that says, yep, I'll give up my Thursday evening for you. But obviously I think it shows a real passion for palliative care amongst all of you, that you're very determined to improve palliative care in the future. or you've just got nothing to do on your Thursday nights. I don't know. Maybe you just wanted to fill the time. But yeah, we can send. We're going to put the recording onto our YouTube. We had said it in the email, and we had just said that if